thank you very much, Peter and Linda, for nice introductions. And yes, as Peter said, I've been asked to do what is normally one talk each to take half an hour, both talks in 20 minutes. So here we go. So I'm going to talk to you about precision medicine and early intervention for psoriasis, which I think are really what's going to start changing the game in the way we manage psoriasis. These are my disclosures. And I think if you sort of think about back over history, we think we're being 21st century and modern in our thinking. In fact, Hippocrates usually thought ahead of this 2,000 years ago. And the one thing you take away from this talk is that stratified medicine is really what he says here. It's far more important to know what person the disease has than what disease the person has. And when I studied dermatology, and I guess when many of you did, this was the best treatment we had, cold time. It still is a very good treatment. But it is not a sort of 21st century way of managing psoriasis. And there are a lot of advances that we've made in the over 100 years since this was first introduced. And these advances we show here as we move from what was the Gherkinman regime about 100 years ago through to where we are today, which is this plethora, and we're in a very luxurious position compared with even 20 years ago of having a number of different targeted biologic therapies and increasing numbers of small molecules. And these are the biologics that we have approved for psoriasis in the UK, these 4 key classes. And what we're faced with in the UK, and of course many of you will be, is that we don't have discernible information which allows us to say which patient is going to respond best to which class of drug, let alone each individual drug. I think with time though we'll get there. So this has been transformational, as you know, biologics for our patients with severe psoriasis. It was a real game changer when the first biologics came through. But of course, as all of you know who use biologics, is that the response is variable. Not everybody has PASI 100 or PASI 90, and not everybody is able to maintain that for a long period of time. So what we're still searching for is how can we get patients onto the best treatment for them in the very first go, rather than an experiment, trial and error approach we have at the moment. And of course the future still looks good as far as the new treatments, but of course the new treatments are not new targets for biologics. They're new ways of different forms of biologics which are being formulated in different ways to target the same cytokines, interleukin 17, interleukin 23, TNF. And then a number of small molecules coming forward. We wait to see whether how well they perform in the real world. But some of the data, for instance, such as for the TYK2 inhibitor, deucravacitinib, looks very strong in clinical trials. But we've got a problem coming, as I mentioned, because what I call a gathering storm. Because if we don't get people onto the right treatment first time, we're going to run the chance of multiple failure. And so I call this people who have recidivist psoriasis. A recidivist is a person who goes to prison, then comes out of prison and reoffends. That's like the psoriasis does. You get it under control, let it out, and then it gets out and it goes back into prison. And in each centre, I can guarantee there's probably about 30 such patients who have these characteristics where they've failed all classes of biologics. And then further upstream is what we call super non-responders who failed at least 2 biologics or 2 classes in their first year, who are inevitably going to head downstream to being not responding to all biologics. So the crucial thing is, how can we use what we currently have in a smarter way? And there's 3 ways of doing this, and I'm going to tell you about each of these very briefly. One is stratified medicine, second is lifestyle, that holistic approach, and third is early intervention, getting there early on in the treatment course. And that sort of fits into our overall sort of view of how we should be practicing health or healthcare, and that if you think of what constitutes health in an individual, only about 10% is contributed by healthcare. Genetics contributes about 30%. It's going to vary from disease to disease. But the real big contributor to health, and that's true for psoriasis as well, is lifestyle and environment. And that's obviously a key target. So the move now is moving away from the way we currently practice medicine to wellness and disease prevention. So if you think about it, currently the patient comes to see you, tells you about the symptoms, you elicit the signs and make a diagnosis and then respond to that. That's reactive. In the future, we'll have a lot of information on each patient, on each person, and be able to tell them if they're going to get a flare of psoriasis, or tell them if they're going to develop psoriatic arthritis, and hopefully head it off, which actually is a more cost-effective way of managing people with disease. And that's because we have tremendous armamentarium at our disposal now, which I call these three megatrends: the systems medicine, big data analysis, and the ability of the individuals to measure their own health, such as a good example is a Fitbit. And that those sort of bring together what's called P4 medicine. That's certainly a major strategic aim of the IPC. This is a more holistic form of stratified medicine. So the patients can be participatory in their healthcare. We want to be able to predict who's maybe going to get psoriatic arthritis. Can we prevent patients getting flares, or even prevent them getting psoriatic arthritis, or maybe even prevent them getting psoriasis? And can we personalize the treatments we have to the individual? And that's really the crux of stratified medicine, in part, is that if we had one biologic to give, and if you all had psoriasis in this room, and I had one biologic to give you, I wouldn't know at present, just because of looking around the room, who was going to be, the patients, the individuals who are going to respond, who are going to be the people who wouldn't respond, and who are going to be the few, but still very important few, who are going to get a significant side effect. So what we're doing is taking that trial and error out of prescribing and making it targeted to that patient sitting in front of us. And the way we can do this is by taking together the information we have on an individual, it's clinical, genetic, and immune, and bringing this together to produce an algorithm which will allow us to predict and reproducibly stratify the response of a psoriasis patient to, in this case, biologic therapies. But importantly, it's got to produce healthcare savings that we wouldn't have had before. And what I'm saying is that the test itself and all that goes into it can't finish up being more expensive and thus swapping patients from one drug to another. Now in the UK, we're in I believe an enviable position. We have the tools, the armamentarium to do this. BADBIR is the biologics registry we've been running in the UK since 2007. 165 dermatology centres, big and small, in a long-term pharmacovigilance study of biologics. We have over 20,000 people registered to that. But what's even more important is not only do we have this great clinical database, but aligned to that is BSTOP, run by Catherine Smith from King's College London, where about a third of these patients we have DNA and or serum. So we can then start to use all this information to track response to biologic and look back at that individual patient's clinical, genetic, and immune status. And this is a program called SORT, Psoriasis Stratification to Optimize Relevant Therapy, funded by the Medical Research Council, but by design is industry, academic collaboration from the get-go, also working with the patient organization. And there's sort of the bottom line, there was sort of what we're really aiming for is to get patients on the right biologic, the right treatment for them first time. And this is the sort of complicated approach that we're taking, but you can have drug endotypes. So is there a signature at baseline in that individual patient that they're going to respond best to adalimumab or ustekinumab, for instance? I think we're going to reclassify the disease according to disease endotypes, moving away from the way we currently classify psoriasis to make it much more precise. I'm going to show you just some results. So clinical results, this has come out of BADBIR, but it's part of the SORT program. And we've looked at predictors of not achieving PASI 90. So some of these will be no surprise to you. Having a BMI greater than 30. Interesting, having psoriasis on the palms or soles. The lower baseline PASI, that's just, it's going to be due to the mathematics of assessing PASI response. The lower it is at the beginning, the harder it is to get a PASI 90. Smoking status is important, and unemployment. So being overweight and smoking are obviously key drivers of non-response. And what that means is that general lifestyle advice is equally important as to getting the patient on the right drug. That holistic approach is going to pay dividends because that can also improve the psoriasis on its own. We've also looked at predicting response to adalimumab based on sort of simple pharmacology. If the drug level of adalimumab early on is low, that's a predictor of a poor outcome 6 months down the line. So then you could make a case for having dose adjustment and a more personalized approach to dosing of biologics rather than currently the fixed approach that we use in most patients. We've looked at ustekinumab, and we looked at adalimumab. You know that psoriasis is associated, certainly early onset, is associated with HLA-C 0602. And we've been able to show, and that's been confirmed in other studies, that patients who are HLA-C6 positive are more likely to gain a PASI 90 response on ustekinumab than if they're negative. And conversely, if they're negative, they're more likely to get a better response to adalimumab. Those on their own aren't enough to stratify, but they would go into an algorithm. Work done with Paolo Di Meglio has been able to show that if we stimulate dendritic cells, type 2 dendritic cells with lipopolysaccharide or TNF, that activates them, and that is shown by expression of phosphorylation. And as those dendritic cells mature, they then stimulate Th17 activation due to reduction of IL-23. But then we've been able to show, though, that patients who gain PASI 75, that's the one at the top there in blue, are in response to adalimumab, are the ones who are less likely to get that phosphorylation, that activation of NF-kappa B due to TNF or LPS, whilst the ones who are non-responders are more likely to be more actively phosphorylated. So using peripheral blood mononuclear cells, where we can extract dendritic cells, we can predict which patients are going to have a poor response, that's not getting PASI 75, and who's going to get a PASI 75 with adalimumab. And it seems to be pretty accurate with about a 90% specificity. I could go into a lot more detail on transcriptomes, but I don't have the time to do that. So a personalized treatment plan, we get them on the right medicine. I think we're developing these algorithms now which will allow us to get there. But you have to combine that with lifestyle management, weight loss, stopping smoking, stopping alcohol consumption, exercise, diet, sleep. All of those are going to benefit psoriasis on their own, but combined with the right medicine is going to be very powerful. So let's move now to this other part of this talk, which is around early intervention. And we all know the sort of long-term consequences of living with psoriasis. There's this cumulative life course impairment. So some individuals who are less vulnerable to that can cope. They keep that balance level. But those who are more vulnerable, and that's true of a lot of our patients, are unable to cope after a period of time unless their psoriasis is under control. And that sort of leads to, again, I mentioned Hippocrates at the beginning. This is something that's not new, early intervention in psoriasis. John Ingram was a professor of dermatology almost 70 years ago now, and he wrote this article in the British Medical Journal where he stated that patients treated at the time of onset of disease remain clear for 20 years or more, whilst if it was delayed, the chances of them remaining clear was reduced. So he's advocating early intervention even at that time. And we know that actually one of the big stumbling blocks in the UK and probably other countries is the delay from the referring the patient with psoriasis from primary care to secondary care, so the patient gets the correct holistic management and gets onto the right treatment. And it may take 15 years in the UK. Now, of course, the rheumatologists have been thinking about this for 30 years because they want to get in there very early on to prevent the active joint destruction. So they've been advocating early arthritis clinics for many years. And so have our colleagues in gastroenterology. So treating patients very early on, rather than this sort of step-up approach, so going from one treatment up to the next, they're advocating a top-down approach where you intervene very early with a biologic therapy. And we've been able to show in Manchester that in Badbeer that the longer the disease duration the patients has prior to entry to Badbeer, the more likely they are to have comorbidities. So the longer it is before they start a biologic, the more likely it is to have an accumulation of comorbidities, again advocating early intervention. Now there are some studies, I don't have time, but Alexander Egbo's been part of those, which show that early intervention doesn't necessarily treatment early doesn't necessarily produce a better long-term outcome, and we can debate that. But this study from Stockholm, I think is a very important one. It's a good study, there's a lot of important information in this. One of the key things I've pulled out of this one for the purposes of this talk is that those patients who initiated systemic therapy at or before they were enrolled into this long-term prospective study were less likely to have severe disease 10 years later. So early intervention produces a better outcome 10 years later on. And we advocated this a number of years ago, Rosita Saraceno and myself, that maybe we should be using systemic therapies early in the disease, and even during the first episode of even guttate psoriasis. Now, actually, even before you start to manage psoriasis and refer those patients, you've got to get the diagnosis right. That's something that came out of our Global Psoriasis Atlas work. We saw that a lot of patients, particularly in low and middle income countries, were misdiagnosed as having tinea corporis and were not managed as psoriasis for maybe 10, 15 years or more. So the diagnosis was missed. That's also true in the UK. We've shown exactly the same thing happens in primary care in the UK. GPs miss the opportunity to make the diagnosis. They diagnose it as eczema, psoriasis, rosacea, tinea, and the diagnosis gets delayed. So what we've done working with the IPC is with the GPA, we've come up with these clinical diagnostic criteria for psoriasis to make the diagnosis clinically for people who are not dermatologists. And note that we actually take into account the appearance of psoriasis in skin of colour, crucial area, and we're going to talk maybe more about that. So you have to have that one essential criteria and at least 4 of these other 8. And then combining this then with into a diagnostic tool, not using clinical photographs, but using medical illustrations of psoriasis, because we feel that's better to get people to be able to diagnose the disease, a bit like a field guide for bird watchers, is that they don't have photographs in a field guide, they have artist's rendition of what that bird should look like with the key diagnostic markers. We've trialled this during COVID actually with non-dermatologists in Greater Manchester, and we've shown that this improves the diagnostic capability of general practitioners, nurses and pharmacists to diagnose psoriasis. So obviously you want non-specialists to be able to make the diagnosis. So that leads then to early intervention. So you're going to see the patient early on, and that's going to hopefully allow you to have an opportunity to educate the patient, to intervene with the correct treatment and screen for comorbidities. In Manchester, we set up what we call the Rapid Access Clinic, where patients are referred from primary care at the first diagnosis of psoriasis within just a matter of months. So we're seeing a different cohort of patients that we would see in our tertiary referral clinic. And we can go into more detail how we did this, but it's actually run out in primary care. So it's not in the hospital, it's in an easily accessible community primary care setting. There's a dermatologist, a nurse, and a psychologist who see these patients. And this is the first data, the first 40 patients. And what we're seeing here, some of these patients have quite extensive disease. We're picking up newly diagnosed hypertension, hypercholesterolemia, anxiety and depression, and maybe psoriatic arthritis. So already they've got comorbidities which require treatment. And almost 40% had either phototherapy or systemic therapy. But it may be more important actually, not just to see the patient early, but to think about using systemic therapy earlier. And this is a paper that Peter van der Kerkhoff and I were involved with about 7 or 8 years ago now, where we're advocating these 3 treatment paradigms. And I think the third one is the one that's most relevant, is using systemic or biologic therapy at that first presentation, however limited the psoriasis is. And you think, well, why would we do that? You just want to treat those few plaques. Well, that's because if you look in the uninvolved skin of patients with psoriasis, however mild it is, however limited, there are already abnormalities in T cell and the Langerhans cell function in the uninvolved skin, which indicates straight away that all of the skin is preset and pro-inflammatory to produce psoriasis. So just treating what you can see is missing the bigger picture. So that's the key thing. So to do that, you have to think about early intervention, either with systemics or maybe with biologic therapists. And I'm a believer, very much a believer in this. We need to have the evidence that really is the case. We've got this sort of circumstantial evidence from other disciplines and maybe from some of the psoriasis registers. And Andy Blaufeld gave a very nice talk at the IPC think tank meeting in Miami with his knockout study, which is using high dose anti-IL-23p19 to see if that can actually switch off the disease. This was really based on these very early studies of what became risankizumab, There's a large dose given intravenously seemed to switch off the disease, put it into remission, I'm not going to say cure, into remission for a long period of time. So it may be a consequence of dose, it may be a consequence of actually treating that patient very early while the disease is still plastic and you can actually reverse it. And then there's the initial data that's come out of using this approach with gazalcumab, which is the anti-IL-23p19, where those patients who have that super responder status do very well. You can see here that on the left-hand side, that on the right-hand side, if they've had disease for less than 2 years, they're much more likely to have a very good response. So to close, you know, currently I'm working in London. If I wanted to guide you around London, I wouldn't show you a photograph of London. I'm going to say, what a great place. You've got the London Eye, you've got the Houses of Parliament, all the rest of it. But to tell you how to get from the Houses of Parliament to Tower Bridge would take me a long time to explain to you. But the way to do it is a sort of stratified molecular approach. You use the London Underground. So I can say you just have to get on the train at Westminster and then go and change or whatever, and that will get you there. You don't even have to know what's going on above ground. You just follow the wiring circuit, and that's really what stratified medicine is about. So I've shown you very quickly that I think the way forward is proactive P4 medicine using algorithms to stratify their approach. I think there's a lot of mileage in early diagnosis, early referral, education, holistic treatment pathways to identify and prevent those comorbidities early on. I think there's some emerging evidence for early intervention, but it's not as clear-cut as I think it could be or should be. And then, you know, should we treat with systemics very early on in all patients? That's for discussion. And if you want to hear more about that, there's the ISID meeting, which I think the IPC are going to be at that as well in Tokyo in 2 months' time. Thank you.
I think we have time for a few questions. Peter?
Chris, when I understand it right, then in the early intervention clinic, you see already signs and symptoms of cardiovascular disease, although these patients have only 1 or 2 years psoriasis. And that also is in parallel to the IPC study in pediatric psoriasis,
yep,
where we observed already in very young children increased body mass, increased frequency of metabolic syndrome. So what does this mean for screening of cardiovascular disease? Does it mean that we have early on, when there is psoriasis, that psoriasis is an indicator disease quite early on for cardiovascular disease? And what for advice do you have with respect to screening?
Well, there's two things there. I mean, so the bigger discussion is whether psoriasis is an independent risk factor for cardiovascular disease. I don't think it is. I think actually it may be the other way around. As we've discussed previously, there's a very nice study from Michigan showing that actually cardiovascular disease may actually be a risk factor for developing psoriasis, as is obesity. It's the other way around, which may be what's happening in those children. They are not obese because of psoriasis. They're getting psoriasis because the pro-inflammatory events of the obesity is stimulating this. But what it does mean is that all patients with psoriasis, it should be the response of the GP or ourselves. You should think about cardiovascular disease and do early screening for it, and actually advise about diet, check their cholesterol. All of those things are going to be important because they share the same risk factors for cardiovascular disease, and it may be part of a greater systemic inflammation, not necessarily because of the psoriasis, it's just that these patients are susceptible to that.
Chris, there's a lot of debate right now about the data on prevention of psoriatic arthritis.
Yeah.
So treating with the biologic, does it prevent PSA?
Yeah.
And then you talked briefly about preventing just comorbidities in general, and how there is a debate whether, you know, if you treat early, you can prevent comorbidities in general. I think it's off mark, the discussion. I personally think that psoriasis by itself is worthy to treat early and hard in every single person. If you think about cumulative life effect, like Alexa has shown, you know, just having psoriasis untreated is a horrible thing. It's a horrible thing for the person with it. And we as a specialty should, okay, yeah, it'd be great if we could say, you know, you can prevent PSA, heart disease, whatever, if you treat early. But why don't we just say treat people early because they deserve it? Because psoriasis by itself is a horrible thing, and improve their lives.
Well, and in fact, that's exactly what I'm saying. I'm saying, you know, treating the psoriasis itself is important, but there's also these added, this collateral benefit, if you like, is that I seeing them early, treating them early, we don't have the good data yet, it may prevent the development of other diseases which are linked in some way to psoriasis. But yeah, I absolutely agree, which is why I mentioned, you know, treating systemically rather than treating topically or locally is going to actually normalize maybe that whole pro-inflammatory events taking place in the skin and bring that back down to baseline. I mean, there's an interesting discussion to be had as to, you know, what is the difference between remission and cure, and can we actually achieve the latter? And, you know, there's been the debates like that on arthritis, and is that truly possible? And it might be, I believe, with the newer advanced therapeutic approaches with cell therapy.
I think the implication, though, is that psoriasis is not serious enough, right, to treat early and hard or something like that.
No, I understand what you're saying, absolutely. But I'm saying I'm added, you know, there are other aspects to it, you know.
Thanks so much.
Thank you
Okay,
so
yeah.
much, Chris.